now to get to what we're all really here for is a presentation from Dr. Steve Kravet, who is professor of medicine here and the head of our Johns Hopkins Community Physicians practice, which is the largest primary care group in Maryland. We're very excited to hear from him, as well as Jennifer Bailey, who is a Senior Director for Quality and Transformation within Johns Hopkins Community Physicians. And I won't go into, you have their details, so you have all the fantastic information about their impressive careers, and at this point I will hand it off to them so they can enlighten us on what they've been working on over the last years.
Great. Thanks, Michael, very much. This is Steve Kravet. I appreciate the promotion. I'm actually associate professor. I'll use your reference if I ever put in a letter for promotion to professor. That would be terrific. Here at Hopkins, I serve in a couple of roles. Jenny will share hers in just a moment. But as we talk through our structure here, you'll understand how matrixed we are. We have roles through the Armstrong Institute, which is really the lens through which we are thrilled to be sharing this information. It's a beautiful Friday afternoon here in Baltimore, a little bit breezy, but beautiful sunshine in the mid-60s, although they say it's going to snow over the weekend, which is just absolutely incredible. And our basketball team here in Maryland is going to play in a little bit over 2 hours in the NCAA tournament, and we're quite excited about that. I'll let Jenny introduce herself briefly, and then we'll jump into it.
Hi, good afternoon. My name is Jenny Bailey. I'm, as Mike mentioned, I'm the Senior Director of Quality here within Johns Hopkins Community Physicians, and as well as in the Armstrong Institute and the Office of Johns Hopkins Physicians.
Great. So I always like to start a presentation where we talk about how we've chosen to do things in our organization by sharing what the organization looks like, because I recognize that every organization is a little different, and to generalize and think about how some of our concepts might fit into your world, it's, I think, valuable to understand how we're governed and how we're structured. So Johns Hopkins Medicine is a virtual organization. It's made up of the Johns Hopkins Health System and the Johns Hopkins University. This is an important slide because the governance of Johns Hopkins Medicine is driven from the Board of Trustees, and the Board of Trustees are actually the group that oversees our quality and safety. Johns Hopkins Medicine Board of Trustees are subsets of both the Health System Board of Trustees and University Board of Trustees. It's a national board with prominent folks from around the country and frankly around the world, as you would expect in a prominent institution. And that subset of the board then governs Johns Hopkins Medicine. On the health system side, we have our hospitals that you can see listed there, and then our organization, Johns Hopkins Community Physicians, is also a fully owned health system company. We're all nonprofit 501c3 companies that all together form up the Johns Hopkins Health System. On the school side, it's predominantly the School of Medicine that constitutes Johns Hopkins Medicine, although we have schools, as you would imagine, School of Public Health, School of Nursing, School of Engineering, many others that roll up to the university. The Dean of the School of Medicine is the CEO of Hopkins Medicine, the head of Hopkins Medicine. The President of the Health System is the Executive Vice President of Hopkins Medicine. And so because of that physician administrative dyad, this is the governance that creates balance for us in our organization. Just briefly, on the bottom there, we have an international group. We do work around the world. We have a home care group where we provide services throughout, home-based services throughout our region. And then we have an insurance plan, Johns Hopkins Healthcare, and through that plan we manage 4 lines of business: Medicaid, a commercial line of business, for the Department of Defense, our own self-insured plan, and now a Medicare Advantage plan. We also collaboratively run an ACO, a Medicare Shared Savings ACO as well. So all together, these are the assets that make up Johns Hopkins Medicine, but a valuable understanding is this combination of health system and university leadership that allows us to try to bridge some of the natural tensions that occur between the differing missions, sometimes between the business sides of the hospital and the academic interests of a university. Geographically, we're spread out largely between the greater Baltimore and greater Washington areas. The red rectangles are hospitals. The green rectangles are multi-specialty health centers. The blue dots are our outpatient primary care sites, mostly primary care, some outpatient specialty care, again, sprinkled out throughout those regions. We fully employ our providers in Johns Hopkins Community Physicians through the health system. The faculty are employed through the university, but we work shoulder to shoulder as Hopkins Medicine, and as you could expect, our patients really don't know the difference. They see us all as Hopkins providers, so we work very hard to integrate our governance, and so that's going to really be the focus of our conversation today. Now, from a quality and safety perspective, our leadership runs from the Board of Trustees right down through each of our entities, and we'll talk a lot about that over the next several minutes. The Johns Hopkins Medicine Armstrong Institute Patient Safety and Quality Board Committee is a subset of the Johns Hopkins Medicine Board. It officially reports up to the Johns Hopkins Medicine Board. Dr. Pronovost, whom you've met, leads that Armstrong Institute and serves as the conduit to the board. But there is a board and prominent board members that we're held accountable to from a quality and safety perspective. And we've created several different lanes for managing our quality and safety. It started in the inpatient areas, and as many places have, we now also have, and each of these areas has a chief quality officer. We have a pediatric area, a population health area, home-based services, Johns Hopkins International, ambulatory procedures, which is a focus on ASCs, and then our ambulatory practice domain that Jenny and I lead. I'm the Chief Quality Officer. Jenny is Senior Director for Quality and Safety, and together as a dyad, we help lead that lane. But you can see that the expectation starts at the board and is distributed down in this way in our organization. Okay, so with that introduction, I want to share with you our objectives today for our presentation. First, we want to talk about how you might leverage a framework, actually two frameworks. Michael talked a bit about this notion of collective accountability. We hope that we're going to demonstrate collective accountability by leveraging a framework. We're going to talk about how governance plays an important role, why and how it's important to clearly communicate goals, scope, and roles, and then ultimately how we think about linking outcomes to accountability. So Lauren shared the PHOA framework. I'm going to share with you two frameworks. Hopefully you're familiar with the first, and then the second one is our framework that we'll introduce to you. The first framework, excuse me, is Baldridge, a framework that I love, a framework for organizational excellence. The beautiful thing about Baldridge is it starts with leadership all the way on the left, and it promotes a balanced structure that ultimately leads to aligned results. It's really beautiful. So the leadership domain leads to a strategic planning domain, a customer-focused domain. Number 4 is measurement, analysis, and knowledge management, really how information is shared throughout your organization. Nothing can happen without integrating the workforce so that people have to have meaningful roles in all of the other parts of the organization, including strategic planning. Of course, the workflows and the operations are critical, and that's where some of the lean principles come in. And lastly, all of those things together drive results. I love the Baldridge framework, and what we're going to do is we're going to show you how the Baldridge framework is actually interposed with our approach towards managing leading safety. The second framework that we want you to understand is our ambulatory quality and safety governance. So what you saw before was the breakout from the Board of Trustees down to each of those different areas. Now this is just the ambulatory practice area. So this is that one box from the slide I showed you a few slides ago. It starts with the Board of Trustees, and through the Board of Trustees, the subset of the board is the Patient Safety and Quality Board Committee that I mentioned before. The role of that committee is to establish oversight and accountability for quality and safety so that everywhere that care is delivered within Hopkins, there is line of sight that wherever a practitioner is, wherever a practice exists, there's a line of sight accountability that we can describe the understanding and hierarchy from a quality and safety perspective. Now, the next lane down is our Quality and Safety Joint Council. Because we have this health system and the university that work together with faculty and health system physicians, we've created an Office of Physicians We all work together through the Office of Physicians. Jenny and I have roles there leading quality and safety through the office. It's the role of our joint council, and by the way, we have a partnership operations council that focuses on operations, but our joint council's role is to lead quality and safety. We collectively define the standards and we monitor the performance of all the constituent entities. The next lane down is what we call work groups, where we learn and share. And we learn and share according to these important domains of the Armstrong Institute. Outcomes, patient experience, patient safety and risk, which is kind of procedures, and also patient safety and risk from a perspective of culture, and then lastly, value. And the lowest part of the organizational chart is where the execution occurs. So we're moving from leadership to execution, and that's the theme that you're going to hear today. And this is each of the entities. And each of those entities has a process where they do local performance improvement. Our job is to facilitate. Their job is to execute.
So with our joint council, when we first started it, we initially decided to draft a charter. And the purpose of drafting the charter was to really crystallize the governance structure. And it's not a very lengthy charter, and we're going to walk through each of the components of it today. But it was an opportunity to really clearly define roles and responsibilities within each of the lanes that Dr. Kravet just described. I think it's really important for everyone to understand where we have commonalities, and actually even more important for everyone to understand where there are differences, and that's okay as long as it was written and defined into our charter. Through the charter, we also had a very clearly defined scope in each of the committees that we had, and defined membership leaders, et cetera. And we've been able to share this project charter as a consistent document, and it's something that we have referenced back continuously. It has evolved since we first started it about 2 or 3 years ago, and we continue to update it and evolve it as we come up with different physician integration strategies, different structures in terms of aligning physician groups, et cetera. So it's been a very helpful document in terms of really solidifying this governance structure.
So what I'm going to do, and Jenny and I are going to pass back and forth, we're going to walk through this charter, and we're going to demonstrate for you how the elements of the charter are linked into the Baldridge domains and into our quality and safety structure. And so hopefully through this you'll be able to get a better understanding of this governance and how the structure actually helps drive accountability. Let me see if I can grab a pointer here. Good. Okay. So you'll recognize this box was the box from our quality and safety governance that I showed you before. That's the Armstrong board. And I told you before that that board establishes oversight and accountability. If you go back to the concept of Baldridge and this beautiful balanced framework, essentially what this is showing you is the leadership triangle. The leadership triangle are the first 3 elements of Baldridge, including leadership, strategic planning, and the customer focus. As I mentioned, our Board of Trustees it's a national board, somewhat international board. Many of them are customers, and through that lens, they share a customer focus, whether they're our customers or they've sought healthcare elsewhere. And we all collectively participate in strategic planning together. Again, this is the board level where we're establishing oversight and accountability. The board role, if you think about the leadership part of it, the board is, as I mentioned before, led by a subset of the Johns Hopkins Medicine Board of Trustees. Our role there is to establish the goals that you see there, establish national leader strategy, to provide an enabling infrastructure for success, meaning all the stuff that Armstrong Institutes and other quality institutes do, data sharing, analytics, lean processes. And then lastly, to maintain accountability to assure that goals are met. I shared with you before we have these 5 domains. Actually, I shared 4 of them. The 5th domain is healthcare equity that is not mentioned before. And so each of those lanes, the work that goes on in each of those lanes is how the Armstrong Institute has defined itself. And again, this is all part of our leadership, and I would argue is what drives our accountability model.
So an example of how we execute on strategic planning is through our annual strategic objectives process. Every year, actually in the spring, this time of year, we go about a process by which we define goals for the upcoming fiscal year, which for us begins July 1st. And we have ambulatory focused quality and safety strategic objectives, and each entity has them linked to their annual strategic plan, as well as they're linked to incentive payments for executive leaders and directors. And that type of accountability is extremely helpful in the process. So again, this is just an example of some of our objectives that we do, and you see that there's a grading system for how well you can perform. There's a pretty simple scoring system around either you're not meeting, you're meeting it partially, you're meeting, or you're exceeding, essentially with these different checks.
Great, thanks, Jamie. So the nice part about it, that last framework is that there are very specific criteria that are mentioned. We report on it quarterly. Every entity reports. So we have this nice dashboard that we're able to use as our guidepost. The next lane down on that organizational chart was our joint council that I described is run through what we call the Office of Physicians. Again, the Quality and Safety Joint Council, and you'll remember that I said that here's where we define standards and we monitor performance. So this links to the Baldridge domains through leadership, where we are partially leaders at the board level because we represent ambulatory at the board level, and we're helping to share views of leadership up and down from this particular lane. It's clearly now taking leadership a little further towards execution. If you think about the way the Baldridge domains are organized, I mentioned to you the leadership triangle. In a little while, we're going to talk about the results triangle, and here we are in the middle. So this lane in our overall structure is moving from leadership towards execution, and by doing our process to accomplish that is by leveraging our ability to do measurement analysis and knowledge management. So this is domain number 4, and this occurs at our Quality and Safety Joint Council level. And of course, the customer focus you'll see throughout this entire domain, we continue to ask questions about our customers' input into our patient experience, into how we measure quality. We do that through patient and family advisory councils and in other ways. But again, all of this is run through this joint council level where we're setting the yearly standards. And those standards then get translated up, as you saw before, into those scorecards that Jenny shared. Okay, so we're moving now to what the Joint Council's role is as it's defined in the Charter. Again, remember 3 things that we're balancing here in our communication. We're balancing the Baldridge domains, we're balancing the structure of our hierarchy and each of those lanes and how they fit together, and then lastly, the importance of setting clear goals in the Charter so that everybody understands their roles. And so the Joint Council role is to carry out board goals, to make sure that it has good representation across all of our entities, to provide a table for conversation up and down, as I suggested before, and then to get feedback so that the goals that we're choosing are reflective of what's important to the key stakeholders.
So this is an example of our Joint Council dashboard. As Steve mentioned earlier, these are directly linked to our strategic priorities, our annual strategic priorities. And again, this is a little bit of a fluid document. We may update these as new priorities come about. You can see we have the columns are entities within our organization, and some of our measures are applicable to some of those entities and some aren't, which is fine. Each of the rows, the major themes of rows, are linked to our 4 domains within the Armstrong Institute. So again, safety, outcomes, experience, and value. We review this every month at our joint council meetings, and this is just an example of the high-level dashboard. This is actually the same dashboard that gets presented at the board level, but there are drill downs within each of these areas that look at individual site performance, provider performance, and all the way down to the patient level. This is just the highest level that gets reviewed. I think what's important about this is that where we see red, and obviously there is some red on the dashboard, we discuss that during our joint council meetings, and we talk about where we have those variances, and we're linking that to our accountability model. And we may bring in guests to that meeting as that are more accountable for certain metrics than others, certain departments. So as an example, we hadn't performed all that well around our postpartum care, and we brought in our GYN leaders to a meeting so that we could talk about improving that process. And that's our accountability model, where we are bringing people to the joint council and helping us understand how we as a system and individually can improve these measures. And this really gives us areas of focus and opportunity.
I'll mention just to anchor this, that this dashboard concept is how we do measurement analysis and knowledge management. And again, that's the example of the Baldridge domain.
And then linking it back to the leadership, we take that dashboard and we create a report that goes to the board. And it's called a management discussion and analysis report, or we've coined it now the MD&A. These MD&As were suggested by one of our board members who had used it in their business, a non-healthcare business, to report budget variances. And we use the same structure to give a written report of how we're doing in our ambulatory setting. The process is almost more important or equally important as what we're writing down. So we ask each of the individual entities to write up their own MD&As and explain why they're having red or why you're having some variances, and just walking through that process forces you to recognize where you're having deficiencies, and also it forces you to sort of get the right people involved to help improve it. So we've really found, again, this process of writing down these variances and these action plans extremely valuable. Dr. Kravet does formally give a verbal report of this MD&A to our board. It's actually a board subcommittee right prior to every board meeting.
I'm going to pause for a minute, and I'm going to take us back to slide 22. Just to remind you what the Baldridge framework looks like. So we were starting back here in the leadership domain, and we're slowly working our way across to where we get to the result lane. And so we were just focusing kind of in this area here at our joint council level, and now we're going to move down to our work group lane. And as we get into our work group lane, we begin to bring in a little bit more of the operations, which is more about where the rubber hits the road. Okay, so our work group lane, where we say that we share and learn best practices, again, organized according to those 4 or 5 domains. We need to update our slide to represent the health equity, which we added very recently. As we do this, as I suggested, we're trending further into execution. It leverages the workforce because frontline people are participating in these work groups. It leverages the customer through many different ways, including our PFACs and our patient experience surveys that give us feedback on the work that we're doing. And it clearly leverages operations. And I think that this is a really important point, and it's actually been a point of contention that we've been working through here at Hopkins. A lot of people want to believe that those that are responsible for quality are the people with quality in their title. But the truth of the matter is that everybody's responsible for quality, and that was the comment that I think Michael made earlier about collective accountability. Where the rubber hits the road is where the providers are providing care and where the care teams, the operations people, are helping to provide care. And so if you don't bring those people to the table and actually assign them the accountability to understand the dashboards and to report on the variances, they're never going to be engaged. So it's been a tough challenge for us to actually move that forward, but we've successfully now kind of ingrained in our culture that the people who are reporting at the entity level and participating in these work groups are the operators, are the doctors, the nurses, the administrators, the MOAs, the MAs that are participating in delivering the care. And again, that's how you can actually learn, because the people who are in leadership roles aren't necessarily the right ones to be sharing best practices. It happens nicely when you have folks further down in the organization talking to each other. So how does this link to our charter? Our work groups are called out there, and there are a couple of different examples: the quality work group and the patient safety and risk work group. And again, very specifically what the scope is, what the membership is, what the roles are. We point out that group learning is intrinsically motivating, and again, they're working together on system-level processes that cross the different entities so that we can help lift each other up.
So one of our work groups, as Steve mentioned, is around patient safety. This is an opportunity to really bring leaders and staff together from these disparate entities and departments. I actually do facilitate them. We have a quality facilitator that serves as a neutral party, if you will. I help set the agenda, but I enlist input and feedback from those that are participating for what to put on the agenda. They have really been highly valuable from a number of reasons. Team building, for one, where you're just learning from your peers and getting to know your peers across entities. So not just in these work groups will they be sharing and learning, but it establishes a relationship so that if there are smaller problems or things that we need to ask of one another, that they can reach out to these peers who have common interests and areas of expertise. They're very well participated, which leads me to believe that people really enjoy them. And I actually do get direct feedback from a lot of people how much they enjoy coming to them. It just really engages the work group members to be able to share, to both share their wisdom, but also to learn from others' experiences. We focus the work groups on two things. As I mentioned, we do a lot of sharing and learning. We just talk about experiences, related to certain topics, and it's just an opportunity to share certain best practices. But as Steve mentioned, we also work on system-level issues as a group, and this collective learning helps. It really just helps motivate you to want to get stuff done, and you feel like you can accomplish some of these bigger things that require a group of people to work on them. And so one of the things that we've done as an output of this work group around the safety domain is we are looking at the CUSP training materials. And what we found when we were rolling out this CUSP training in our ambulatory settings was that some of the training materials didn't really resonate with those that were in the ambulatory setting. A lot of them started from an ICU type setting, and the ICU checklist, while in theory could apply, it just wasn't resonating as you were trying to think, what does a CUSP team look like in ambulatory? So a group of us got together using a design thinking process, and we updated several of the CUSP tools to be more ambulatory specific, and they will be branded as an ambulatory CUSP tool. We had one of those sessions back in the fall. We actually have another one planned for next week where we'll be tackling another set of tools. So this has been something where we've been able to come together, work together as a group, and improve a process and a system level issue.
Okay, so if you're following along in theory here, you are recognizing that we're moving further down to the lowest level where the rubber hits the road, local performance improvement across all of our entities. And each of the bubbles that you see in this lane represent different entities, all part of that original organizational chart that I showed you of Hopkins Medicine. Every one of these represents a different company within Hopkins, but every one of these different areas has ambulatory practices. And so how do you then take all of the things that we've talked about to this point and distribute them down in a fractile way so that within the entity, execution is able to occur and we're able to drive successful performance improvement. This area here is where we talk about the results triangle or the outcomes triangle in the Baldridge domain. It's 5, 6, and 7, the last three domains within Baldridge, where the workforce is working through their workflows, to arrive at the results. Remember, everything else up to this point has been influencing it. If you start at the left, you're thinking about the leadership and the strategic planning and how we've listened to the customer's voice. This is where the rubber hits the road. The thing that's so interesting about this is that each one of these different parts of Johns Hopkins Medicine, and I'm sure the same is true for your organizations, every one of them has a different flavor. Some of these are academic institutions where we have residents and medical students and fellows that are delivering care. Some of them are purely community organizations where there's absolutely no teaching or academic things that occur. But the quality and safety really supersedes all of that, and the same standards are aspired towards for all of the different areas where care is delivered. But you can't run an academic practice like a community practice, and you can't run a community practice like an academic practice. So our role is to set direction and to facilitate, but the expectation is that this is where accountability exists, where the execution occurs, and where it doesn't, we bring people up higher into the conversation chain to see how we can help them, but to reinforce that the accountability is important. These PI committees are defined in the charter. They talk about execution. We specify that it requires the right people and who those right people should be. And we acknowledge that local structures vary by organization, and that's the best way to drive internal practices.
As Steve mentioned, we have performance improvement committees at every entity, and really engaging the right people and bringing them to the table is, I think, one of the key attributes for success. You need that balance of clinical physician leadership as well as administrative leaders, but also some supporting roles, people like training, for example, IT leads, and others, supporting departments, all sitting around a table collectively figuring out how to do this execution. This is just an example of an agenda from one of our performance improvement committees at Johns Hopkins Hospital. And you can see that these agendas are actually structured, again, in the same way as the Armstrong Institute domains around risk, outcomes, patient-centered care or experience, and values. It's cut off here, but we use that same structure in all of our quality committees. And each of the groups can work on local efforts in terms of improvement. Everybody has something different that they need to work on in terms of a risk or some type of metric that they're doing worse on than others. And these local efforts are really important. They should be individualized. People should feel autonomous to be able to drive these local improvements. So this is just an example of one. We were having some issues around making sure that staff were asking for 2 patient identifiers. And we did an assessment and recognized that it wasn't as good as we wanted it to be. And we developed a process for people we reminded people, we developed an education process for people to always ask the 2 patient identifiers. We created a button that actually said, "We ask because we care," because we found that staff felt like it was a barrier to ask patients because they had known patients their whole life. They knew Mr. Smith, and they didn't feel comfortable saying, "Mr. Smith, what's your name, what's your date of birth?" So we did a little campaign around helping patients understand that we need to ask this for their own safety. This is just, some local measurement we did around that. And after our education campaign and awareness campaign, we were able to improve. And so that's just a way how we can use, local intelligence and data analysis to drive change. Another example that we use for performance improvement locally is our A3s. A3 is a lean structure that we use here throughout Johns Hopkins Medicine in both the inpatient and ambulatory settings. Our quality and safety teams help facilitate the local PI, but we are really just facilitators. We are not the people creating action items and really doing the work. And that's the key, that the people at the sites use these A3s to really implement the action items and drive performance improvement. We've helped facilitate analysis. This is an example of a fishbone. We have other methods, quality improvement methods that we use to help facilitate the analysis phase. But I just want to emphasize again, our role is only facilitation and to help them. We bring data to help with that process. We show measurement, over time to show improvement processes. But this is something that the local sites are really owning.
Great. This is our last slide. It's the webinars are always so interesting because I only get to see Jenny's reaction and she only gets to see my reaction. So we're very much hoping that folks are following along and are engaged. It's really a privilege to be able to share some of our thinking and our work. We're passionate about quality and safety. I think life is really complicated, and so whenever there is a successful framework to leverage, we should be leveraging it. And I think the only debate that we should be having is which is the framework we want to use. And there are so many different ones to choose from, and quite frankly, it doesn't matter which one you choose. But choose one because it forces us to think broadly. When we dive into analysis and we dive into conversations, if you don't have a framework, you're always going to forget some of the elements and some of the domains. So leverage a framework. Governance is important. Accountability needs to be set at the highest level. It needs to be set by leadership. Leadership needs to be present. They need to walk the walk. But you know what? Execution is where accountability needs to ultimately lie. And when you're not executing, folks need to be held accountable as to why, and leaders need to provide the resources that are necessary to accomplish those goals. When you put an organization like this together, having a charter where all the different elements are clearly communicated not only helps you explain things internally as new people come and go, or new people come and people go and move around the organization, it also helps you explain, just like we're doing today, how this could be disseminated and scaled, and it allows us to get feedback and inputs from others. And then lastly, this notion of linking outcomes to accountability, where, as I suggested before, at the entity level, where every entity is different, the leaders of those entities need to be involved and engaged, talk the talk about quality and safety, and to be part of the accountability model. So we really appreciate and thank you for your time listening to us today. I think we might have time for a couple questions. I'll turn it back to our hosts.
Excellent. Thank you both. That was a fantastic overview of some incredibly complicated issues. And at this time, absolutely, we have some time for questions. Please put them in the chat box, or I believe you can press *1 on your phone. If you'd like to ask the question over the voice line, that would be great. There's a few things in the chat box. One being, of course, if you'd be willing to share a blank version of the template of the dashboard that you use with the group.
Of course.
Excellent. So we'll follow up with you guys to get that to the group. And I think that, so I'll start, while people are taking some time, and please take this opportunity to kind of share with what you're doing, and two is from an organization using the Baldridge framework. And I have to say, we're sitting in the room listening, and I think for all of us here, that was the clearest kind of description of how you would actually operationalize, I think, Baldridge that I've ever heard, which is great. I think one of the things that kind of scares people off Baldridge a little bit is it's so comprehensive that kind of where do you start? And as people are kind of starting to, we've got some answers from Ann about where you start. But thinking back kind of on what you guys have done over the past few years, what do you think, if people are earlier on in this journey, what do you think they should kind of pick, or what were some of the areas that you started working on to kind of build all of this infrastructure in this system?
Well, good. That's a great question. And here's the challenge that we have. We've put what we think is a pretty nice structure in place to talk about ambulatory quality and safety. But as you all recognize, ambulatory quality and safety is very far behind the inpatient world in benchmarks, national standards, processes, and quite frankly, resources. So we're in that awkward situation where we've learned how to ask really good questions about culture and about how the next patient's going to be harmed, but we don't have all the resources that we need to be able to address those gaps, and that makes it hard to sleep at night sometimes. So I think the most important thing that you need to do as an organization is start off by saying, how's the next patient going to be harmed? And to have a culture of a safe and open culture of how those conversations can occur with the right protected environment from a board and compliance perspective, so that those conversations can occur in a protected way. And so then you have to prioritize, and you have to have a way of prioritizing, because where you start has to be what's going to have the greatest impact on the severity and frequency of whatever the challenges are. Again, governance is important. Leveraging your existing culture and structure is important. And as Ann points out, it all starts with a very much a top-down culture. Mr. Armstrong, the benefactor that created the Armstrong Institute, attends the board meetings, leads off every board meeting, and holds us all. He reads 140 pages of a board report before every one of our board meetings, and he asks questions that are incredibly nuanced. And we know that we're all being held accountable to the details of our work.
Excellent. Thank you. Just a reminder to folks to star one if you want to ask a question, or any other questions in the chat are great. I think Ann mentioned a couple of things, and you touched on these too, and it seems like one of the themes we've been hearing from lots of folks is it's really kind of about that top-down piece is critical, and it seems like that's what we miss frequently, but the bottom-up piece is absolutely critical too, and it's really about a balance. And it sounds like you guys have put a number of things in place, having the joint council, having the kind of line of sight accountability to really, it seems like, remove the distance from the top to the bottom a little bit, or at least make it a little transparent about what's going on at different parts of the organization. Have you had any challenges around that? I know there are challenges around that, but have there been any particular things that have stood out around trying to balance that kind of top-down accountability with some bottom-up ownership? Anything that is, any kind of guidance that you have for the group on how to do that?
Michael, another great question. I think one of the greatest challenges is the complexity of any organization and the matrices. So if you can imagine, we have doctors that are employed by the university working in practices where staff are employed by the health system. They have different employment structures, different employment models, and even though we all work for Johns Hopkins Medicine and the patients see us as one big organization, how you hold people accountable, how you set goals, how you create incentives are sometimes different. And so, some of the challenges are how one organization might weigh their quality and safety versus another part of the organization, how certain individuals might be held accountable. I don't think I'm going to be speaking too far out of line by saying that, the staff are when given the opportunity, can tell you who the doctors are, who push up against their sense of fairness and their sense of efficiency and their sense of communication. And how do you hold physicians and faculty accountable just like you are staff accountable? And so that's a culture thing, and there can be bumps along the road there. But again, when you lay all these things out and you get people signing on to this from the get-go, it's a lot easier. When people are part of the organization for a long time and you try to overlay a new model, I think that's where you get a little bit of rub, because people will say, well, that person's been doing this for so long, we're not going to really hold them accountable, and that's just wrong. That's where some of the challenges occur.
Great. Excellent. Well, thank you guys so much again for sharing, and we'll do maybe last call. If there's anyone with a question, to either dial in or share via chat. But we just want to thank you again for taking the time to put this together. And as I said, this is, for me personally, the clearest articulation of how Baldridge fits into all of this that I've heard. So that was really fantastic. I really appreciate your effort and your time doing that. Thank you.
It was a privilege to do so, so thanks for the opportunity.
Thank you very much.
Thank you both.